Hello.
Hello.
Hey, Brad. Hi, Sophia. Hey, Brittany. I know you're in the car, Brittany, so.
Hi. I'll be safe.
Okay, I'm counting on it. Hi, Kathy. Hi, Casey.
Hi.
All right. I get to cheat a little bit so I can see your screen. All righty. We'll give everybody a couple of minutes and then we'll get started. There we go. That's fine. Yeah. All right. All righty. We'll give everybody 2 more minutes and then we'll get started. Alrighty, so we'll get started. I can always tell when people can actually hear me because everyone's head comes up. It's so nice. So the stuff I pulled today for what we're going to talk about came from Google Classroom. So anybody who submitted questions, I went through them this morning and pulled out stuff that I hope will be helpful. This is definitely going to be participatory. So if you have a question, just interrupt. Feel free to give feedback. We're recording the first session just to kind of see how this goes. I've literally never hosted one of these before, so bear with me. Feel free to give honest but kind feedback. So the big kind of repeating theme for all of the questions was talking about ABG analysis, partially compensated versus uncompensated versus compensated, mixed gases, and then a little bit about needle aspiration and chest tubes, and the hemoglobin oxyhemoglobin dissociation curve. So I tried to cover all of those things today. I didn't put a slide together for needle decompression versus needle aspiration, although 2 different people asked about it, because there was a quiz question in the Google Classroom. And so needle decompression and aspiration are the same thing for the purposes of this test. But for a tension pneumo, it would be much faster to do needle aspiration or decompression than it would be to put a big honkin' chest tube in and have it sutured in place. So the reason it was the chest tube not the chest tube, excuse me. The reason it was needle decompression, or I think they actually used aspiration, was because it takes longer to put the chest tube in, dilate to the correct size, hook it up to an atrium or other chest tube drainage device, where needle decompression, you can just feel the provider, not us obviously, can just feel to the correct intercostal space and pop in a 14 gauge needle and decompress the chest. Because you've got your tension pneumo in that question, so there's the concern about complete cardiovascular collapse. So I wanted to address that one first. This, I pulled the material that's up on the screen, is from a different class. So Joan Kavanaugh pulled a lot of this together, and then I interspersed some YouTube clips that I found helpful and some other material. So let me know if this is helpful, not helpful, and we'll go from there. So quick review: normal 735 to 745, normal CO2 35 to 45. So I always taught that if you can remember the pH being 735 to 745, then you can also remember what the normal CO2 is, because they're exactly the same. You got your 3545, and then your bicarb 22 to 26. Very, very quick review: CO2 is an acid, bicarb's a base. Just want to make sure everybody's got the same stuff, because when we get into talking about it, I just want to make sure everybody's on the same page. A quick review of the Rome mnemonic for looking at blood gases, and I'm going to send all of this to you guys so you'll have it if you want to review it later. I'm going to talk a lot more about this uncompensated versus partially compensated versus regular compensated in a little bit, but I thought this little mnemonic was very helpful. So we're talking about respiratory acidosis. Obviously, your pH is low. It's less than 7.35, and you're going to have a high CO2, which is greater than 45. If we're talking about alveolar hypoventilation, things like respiratory depression, so your patient who's not intubated but isn't breathing, your patient who's maybe a repeated opioid administration and isn't breathing, decreased ventilation, so your pneumonia patients who don't have a lot of alveolar ventilation, and then your VQ mismatch, your ventilation perfusion mismatch, so your patients who have ARDS, patients who maybe have a PE, something that's preventing blood flow from going by the alveoli, any of those that are going to prevent either blood flow picking up oxygen or preventing oxygen from diffusing from the alveolus into the blood itself. So just kind of things to think about when we're talking about respiratory acidosis. So obviously we talked about narcotics, head injury patients. So in this class, not today, but in general, there are a lot of NCCU people. So your head injury patients, respiratory muscle fatigue. So with COVID, obviously, we're seeing a lot of these patients who are struggling. So you're going to see acidosis. Underventilated mechanical ventilation patients. So your patients who are on the vent but haven't been optimized. Either they don't have optimal PEEP to keep their alveoli open. So those are patients who you might drop an esophageal balloon if the patient's paralyzed. You can also do plateau pressures. Respiratory can. Do plateau pressures to see if they've got a good amount of PEEP. Patients who are slow to wake up from anesthesia, or patients who you're waking up slowly, either your alcohol withdrawal patients or your patients who are on DEX. Neuromuscular diseases like Guillain-Barré, and then your pneumonia patients, because you're not getting the oxygen down into the alveoli to cross across into the capillaries. Alkalosis, we're going the other way, 745 or greater, and you're going to see a low CO2. So we don't see a ton of respiratory alkalosis unless we're talking hyperventilation. So if your patient's breathing super fast, they're anxious or in pain, if they're hypoxic and trying to compensate, again, those head injury patients. Sorry, Brad, I'm not a fan of head injuries. And then patients who are febrile, their respiratory rate will go up as part of their compensatory mechanism, and then overventilating our mechanical ventilation patients. So you're blowing off all that CO2, which is eliminating all your excess acid, and hypoventilation means you're retaining. So our COPDers tend to be a little acidotic at baseline because they're retaining that CO2. I know a lot of this is review, but I think it will be helpful. Metabolic acidosis, again, your pH is going to be low, but at this point we're looking at bicarb, so a bicarb of less than 22. So either an increase of acids or a loss of bases. So patients who are septic, lactic acidosis, DKA patients, ASA patients, overdoses, and then the other end is if you've got too much loss of bicarb, so diarrhea or vomiting. Indwelling drains or aggressive NG or OG tube suction, because you're sucking out all of that, can also cause it. And then laxative overuse. So particularly for our lactulose patients or our patients who have eating disorders, you can see metabolic acidosis for them also. The other flip side would be metabolic alkalosis, so again, pH greater than 7.45 with a bicarb of greater than 26. A little bit about the renal system. It's super important, so because all of us are in critical care, knowing that your patient's renal system isn't working is going to play a huge role in whether or not they're able to regulate. So when we talk a little bit about mixed gases, the YouTube clip I have talks about non-volatile acids. So those are things like lactic acid that build up in the blood, but they're not able to be converted to a gas. So buffer. So the most common buffer is bicarb. It's regulated by the kidneys and the lungs. It can also be regulated by the administration of bicarb. Other things that can be buffers are hemoglobin, the big serum proteins, and then the phosphate. And phosphate is going to be really important when we talk about the oxyhemoglobin dissociation curve. Oop. Here we go. So when we're talking about compensation, we're talking about either partial compensation or full compensation. And your pH is going to tell you whether or not you're partially compensated or fully compensated. So very quickly, uncompensated means an abnormal pH and one abnormal value. Partially compensated means abnormal pH and two abnormal values. And then compensated is your normal pH with two abnormal values. So if you're uncompensated, you're only going to have one. Any sort of compensation means you're going to have two abnormal values because the body is trying to correct what's going on. So I pulled this from that YouTube link that's at the bottom. This YouTube video was super helpful. And like I said, I'll share this presentation. So if you want to watch, the video is long, it's 17 minutes. I didn't really feel like it was a worthwhile use of your time. But I thought this slide was super helpful when talking about compensation. And so he gives a quick review of what we just talked about. CO2 being an acid, bicarb being an alkaline. Compensating needs to happen in the same direction. So if your CO2 is going up, so your patient's becoming more acidotic, in order to compensate, your bicarb also has to go up. So when you're doing your ABG analysis, it's very helpful to take a look always at your CO2 first. And then after your CO2, then you take a look at your bicarb. So taking a look down here at the bottom, this is a review of what I was just talking about, that one abnormal, one normal versus what your pH is doing. So uncompensated, fully compensated, and partially compensated. The body doesn't overcompensate, so that's just super helpful to keep in the back of your mind, that the body shouldn't be overshooting. Any questions about full compensation and respiratory acidosis or alkalosis, metabolic acidosis or alkalosis? Okay, so far so good. I have the chat window up too. If you don't feel like talking and you just want to chat, that's okay too. So talking about partially compensated, so there's a slide on each one about partially compensated acidosis and alkalosis. So starting with respiratory acidosis, so it's not fully compensated, so you're still going to see a low pH, but you're going to see both your CO2 and your bicarb head in the same direction. So you'll see both of these elevated because the body's trying to produce additional bicarb or hold on to additional bicarb in order to offset your pH. Partially compensated respiratory alkalosis, same thing. You've got alkalosis, so your pH is going to be up above 7.45, and your CO2 and bicarb are both going to be low because we're trying to compensate for your CO2 being low, so the body's going to drop the bicarb. Partially compensated metabolic acidosis, so your pH is low, bicarb is low, and your CO2 is low. And then partially compensated metabolic alkalosis, pH is high, bicarb is high, and CO2 is high. Questions at all about partially compensated versus fully compensated. So your pH is still going to be off with all of your partially compensated ones, and your pH will be normal with your fully compensated ones. This guy was super helpful. I hope this will play. This talks about mixed alkalosis and mixed acidosis, which is what I feel like we see most often. Oh,
there are no disturbances present right now for this blood gas. But when we see a combination of disturbances happen that both are going to cause an alkalosis, so your respiratory component is going to cause an alkalosis and your metabolic component is going to cause an alkalosis, that's where we end up with a mixed alkalosis. Now remember, in regards to the respiratory component, an alkalosis will be caused when CO2 goes down beneath normal. So let's just say it goes down to 25. Okay? On our bicarb side of things and our metabolic component, we know that when bicarb goes up, that creates a metabolic alkalosis. So let's say that this is 30. Okay? So here we have a bicarb that is elevated. We have a CO2 that is decreased. Both of these will create an alkalosis. So what you're going to see here is an exaggerated alkalotic pH. And what we get when we do this is 7.69. Now, here's what I want you to understand.
He just made up the 7.69. I don't know why he picked that.
Because I see this a lot. I see students who say, oh, it must be a partially compensated mixed alkalosis. Okay, let me help you right now. If you ever have a mixed problem such as this, there is no compensated, partially compensated, compensating. There is none of that. Okay, there's not any of that because you can't have both of your components, your respiratory component and your metabolic component. One can't compensate for the other if they're both going towards the alkalotic range. So does that makes sense, right? So like normally, if your respiratory system was to present in an alkalotic range, such as this, your bicarb would go down to try to pull your pH back down into normal range. Vice versa is true also. If you have your bicarb that goes up, then your pH goes up, and your respiratory component, to compensate, will slow down minute volume. It will hold on to more carbon dioxide to allow this pH to come back down, okay, from the state of alkalosis. But that's not what's happening here. You don't have a compensatory mechanism when you have a mixed disturbance such as this. You have two problem causers and zero players that are trying to compensate. Okay, so there is no partially, fully compensated, none of that. It's just simply mixed alkalosis. Now, what would cause this is what the question is, because you got to say, okay, well, what would cause a mixed alkalosis? And to answer that question, you simply have to go back to what causes a respiratory alkalosis. And we said there were several things, right? Pain, fear, anxiety, right? And then we also said, I'm just going to put up here early, but we also said early presentation of disease processes. Okay, so if a person comes into the hospital and gets an ABG in the early stages of a pneumonia, it will probably present as a respiratory alkalosis because that's what the body does. The early disease process starts creating this shunt, starts causing this mild hypoxemia, and the respiratory system starts to breathe faster and deeper to try to bring in more oxygen to get rid of carbon dioxide before it gets to a state of severity where an acute ventilatory failure phase is now happening. Okay, so typically early phases of all diseases present with a respiratory alkalosis. Okay, remember, if you go back and watch that video, and if you haven't, I suggest you to go back and watch that video, and you'll see where I state this, and I say, you know, don't sleep on these patients, because just because they're not acidotic does not mean they're not going to become acidotic. But for right now, what would cause this person to blow their CO2 down to 25? It can be several things: pain, fear, anxiety, early disease process, head injury. They have a tendency to hyperventilate. So multiple things. You got to figure out which one it is. Then we ask ourselves, okay, well, what would cause the bicarb to go up? Well, one of the things we know in conjunction with just electrolyte imbalances in general is excessive or prolonged use of diuretics. We also talked about metabolic alkalosis being a loss of acid in the body, which would cause your bicarb to be in excess, which would cause a metabolic alkalosis. So maybe also persistent vomiting could cause a metabolic alkalosis. So you see here where you have multiple things going on, okay? And you have to ask yourself, how do we fix the respiratory alkalosis, and how do we fix the metabolic alkalosis? This is no longer about fixing the underlying problem, and the compensatory mechanism will just take care of it itself.
So hopefully that was a little bit helpful, talking about mixed alkalosis and how it's not anything having to do with compensation, because you can't compensate if both of your issues are headed in the same direction.
When we're talking about a mixed acidosis, we're basically talking about the exact opposite of what I just described. I just described an alkalosis where you have two problem causers, the respiratory components in that bicarb or the metabolic component, both of them causing an alkalosis. Now flip the script and take your respiratory component and your metabolic component and have both of them cause an acidosis. Now, if you think back to this, you should understand, you should know, okay, I got this. An acidosis will be caused anytime your CO2 rises above normal, outside of the normal range. So if our CO2 goes up to 55, this will cause a respiratory acidosis. Anytime our bicarb goes down beneath the normal range, 22 to 26, anytime it falls beneath that, it will cause a metabolic acidosis. So now you have a respiratory component causing acidosis with a high CO2, and your metabolic component causing an acidosis with either a loss of bicarb or an increased anion gap, or an increased amount of non-volatile acids. This, again, will exaggerate the acidity of your pH. So your pH is going to be very, very acidotic. That's what it would look like, okay? Now, again, how do we fix it? Well, you have to ask yourself, what's causing the problem? Just like we did with the alkalosis, right? What is causing the problem? Well, we know that diseases, pulmonary diseases, can cause gas impairment, right? So that could cause your CO2 to go up. So certain disease process, especially in the later stages or the moderate to severe stages of it, you'll see CO2 rising. We also call this acute vent failure, right? When our CO2 goes up and our pH goes down, acute ventilatory failure. So this patient could be an acute vent failure. This could also follow a respiratory arrest. Okay? And then what would cause our bicarb to go down? Well, a bunch of things, right? Like we've talked about it. Loss of bicarb. So I'm just going to put two things up here. Loss of HCO3. Sorry about that. Or increase in non-volatile acids. So this could be an example of increase in non-volatile acids. It would kind of be what I talked about a minute ago. If you have DKA, diabetic ketoacidosis, that's an increase. It will give you an increased anion gap because of the increase in non-volatile acids. If you have, say, cardiac arrest, then you're going to lose perfusion to the tissues, which means there's not going to be any oxygen delivery to the tissues, which means the tissues are going to transfer into anaerobic metabolism, and they're going to produce lactic acid, would be a buildup of a non-volatile acid and give you an increased anion gap, which would cause a decrease in your bicarb. Or if you had, say, excessive diarrhea and you had a loss of bicarb, actually losing bicarb through your body, then that would also cause a loss of bicarb. So the question is, what's causing it? And you have to figure it out. There's no difference from when we did our metabolic acidosis video, and I told you have to look at the anion gap. You have to do the same thing here to figure out what's causing this. Okay? This blood gas right here is a favorite trick question of mine. I love giving an example of this blood gas and saying, what do you think happened to this patient? Or I don't really love this because it's kind of bad to say I love it, but after, say we do a code blue, and within that code blue, we got an ABG, and the blood gas looks something like this. Before I give results, I always like to ask, what do you think the blood gas is going to look like? And I always get high CO2s, but I never get low bicarbs. And that's just because the idea of anaerobic metabolism is difficult to grasp for students. And so, but that makes sense, right? Cardiac arrest, the heart ceases to circulate blood, the patient's no longer breathing, so you have a buildup of CO2. And by the time we get a blood gas, we find something like this. CO2 is high, the lactic acidosis is present, so bicarb is low, and we have a mixed acidosis. What do we have to do? We have to treat the CO2, get it down to normal, and then treat whatever the problem is here to get it up to normal. And you'll get your pH restored, okay? But again, just like with the alkalosis, there is no compensatory mechanism happening here. Anytime you see a pH that is being caused by both the respiratory and the metabolic components, it is a mixed disturbance, and you got to figure out what's causing both.
Aside from the accent, I actually find him pretty helpful. So his videos are really good. He's the respiratory coach. I've got the link down here at the bottom, but I think he gives a pretty reasonable explanation. Oh goodness, he's about to start over. Of the two different types of mixed gases. So I'm going to come back to this if people are interested in this at the end. This is the ABG Ninja. This is a free website you can actually go to. It's abg.ninja/ABG. And you can do a ton of ABG practice questions. If people are interested at the end, I'm more than happy to go through them and we can do them as a group. But it gives an explanation. It has you go through, I think, a really good thought process of how to kind of decide what's what. So when you're looking at that CCRN question, you'll be able to say, okay, here's exactly how to break it down so I know exactly what I'm looking at. So I'm going to circle back to that at the end. Questions so far? Okay, a couple of nods, no. So the other thing that came up a lot was the oxyhemoglobin dissociation curve. And this is where I get to nerd out a little bit. So I apologize, but I'm about to get wicked nerdy. And so quick A&P review. I know this is obvious, but just bear with me. So when you're talking about inspiration and expiration, you're talking about the inhalation, inspiration of oxygen, the exhalation of CO2. Gas exchange happens here at the pulmonary capillary level. You've got deoxygenated blood coming through the inferior and superior vena cava to the right side of the heart, CO2 going out, oxygen coming in, blood going back through the pulmonary veins and out to the rest of the body. This is where it gets a little bit nerdy and it's about to get worse. Down at the systemic level, you've got cellular respiration. We're not going to talk too much about ATP, but believe it or not, it's actually relevant. Sorry. But we're going to talk a little bit about gas exchange down at the cellular level. So just remembering that CO2 is produced during ATP production and O2 is used. Otherwise, we end up in a lactic acidosis situation. So where the body doesn't have oxygen to consume, and it produces an increased amount of CO2, but isn't consuming oxygen. This is the super nerd part. And so, quick refresher, all hemoglobin have 4 binding sites. So Your red blood cells have 4 binding sites. Why do you care? I'm going to tell you in a second. But this is really important when we're talking about the oxygen hemoglobin dissociation curve, because at a perfect setup, you should be able to have 4 oxygen molecules and 100% saturation for every hemoglobin. And so this is the dreaded curve. If you've sat through my orientation, which I know Becky and Brad have, this curve should look familiar. I pulled it right from our respiratory lecture. And so our goal is this black line here. So this says that in a perfect world, when our patient is normothermic, has a normal metabolic process, and pH is between 7.35 and 7.45, if I have a partial pressure of oxygen, a PaO2 here, of 80, my SAT should fall somewhere here in this 90 to 100 range. And so this is really what we're looking for, is to get right on this curve. And so when we're talking about patients who have left shift or have right shift, and depending on which PCCM provider you have on the week, you may hear left shift versus right shift. This is the ability of the oxygen to come off of the hemoglobin. So come off one of these 4 binding sites and be usable at the tissue level. And so when we're talking about left shift, we're talking about patients who are hypothermic. I'm going to talk about 2,3-DPG in a second. Patients who have decreased H positive hydrogen ions, so they're alkalotic, or they have low CO. Your reduced affinity, so this is patients who they get rid of oxygen super easily. These are patients who are going to hold on to oxygen and not put it in the bloodstream, and I'm going to explain in a second. So if you've got left shift, we're talking about patients who are cold, patients who are alkalotic. If you're talking about right shift, you've got patients who are febrile or patients who are acidotic. So bear with me here. I feel like I've seen this face mostly in July and August. So again, nerding out here. So 2,3-DPG is actually a phosphate that alters the ability of the hemoglobin to bind to that oxygen. So these are the 4 binding sites, which that pretty red blood cell had for oxygen. And so when we're talking about 2,3-DPG, that means that one of these binding sites isn't going to be able to bind correctly because there's too much of a particular phosphate, to simplify it down. So why do you care? So decreased levels, patients who have multiple blood transfusions. I know we've done at least one massive transfusion recently. Patients who have low phosphate levels, patients who are hypothyroid. The hemoglobin in those patients is going to bind tightly and not be available to use at the tissue level. So you won't be able to extract it off the hemoglobin and use it at the tissue level. And then your chronic hypoxemic patients, your anemic patients, and your hyperthyroid are going to have tons of extra oxygen circulating because it's not going to bind real well at the hemoglobin site, which is great if we're talking about the tissue where we need that oxygen to be available, but not great if we're talking about being able to bind to the hemoglobin molecule from the alveoli from the lungs onto the actual hemoglobin to transport it where it needs to go. So popping back here, we've got our reduced affinity, so our hot patients. Those are patients who are going to have trouble getting that oxygen to bind to the hemoglobin in the lungs. But then once it is bound and it starts to circulate, you'll get plenty of oxygen available at the tissue level. It's really the lungs trying to get it to bind. Whereas our cold patients, we're going to see that they increased affinity. So they're going to bind real well at the lung level, but then they're going to hold on to the oxygen and not allow it to come off the hemoglobin and go into the tissues for use. So we really want to try and push patients, right into the solid black line area here. Make sure that we're really working to keep them normothermic. If they have a thyroid issue, that we're being very careful about monitoring their thyroid. If we've got a patient with multiple blood transfusions, we're monitoring their electrolytes super carefully because that electrolyte issue will play with the DPG. So calcium, which is one of the preservatives and citrate for bagged blood products, you'll see it reacts opposite with phosphate. So as calcium goes up, phosphate goes down. And so your patients who get tons of blood will drive their phosphate down, and it'll bind the hemoglobin and the oxygen closely together. So be super careful about those. Our anemic patients are going to have trouble binding, and then again, our hypothyroid. How'd we do? Helpful, clear as mud, not helpful. Blank faces. Okay, good. Other questions, concerns? Do people want to do the ABG Ninja thing, or are they kind of not into it? I'll at least show you what it looks like. So if you go into, like I said, abg.ninja./abg, this is what'll come up, and it'll give you the pH, the CO2, and the bicarb. I like the way this is set up because when I took the CCRN test, the first thing I did, you're allowed to bring in scrap paper. And so I did a little mini brain dump, and I wrote down like a couple of normal electrolytes. I wrote down normal H&H levels, and then I wrote down my normal ABGs because that was the stuff I couldn't remember. And then I drew the little neuro face guy for the cranial nerves. So on my scrap paper, I had written down my normals, so 735 to 745, 35 to 45, and then 22 to 26. And then I like the setup of this page because it makes you think like, okay, immediately I'm looking at the pH first. Is the patient alkalotic or acidotic? Alkalotic, thank you. Is it a respiratory cause, or is it a metabolic cause, or is it both? Okay, so Casey says it's metabolic. Does everybody agree that it's metabolic alkalosis? Becky's yawning. I'm obviously keeping her awake. Sue says you have alkalosis. All right, so Brad says metabolic also. All right, is this patient compensated partially, fully, or not at all? Okay, Brad says no. So we decided this patient is an uncompensated metabolic alkalosis. And so this patient is metabolic alkalosis, but partially compensated by respiratory acidosis. And so because the patient's PCO2 is high, the patient's compensating, but only partially because we're not down to a normal level. So we'll try another one. So patient is 734, acidotic or alkalotic? Or normal?
Acidotic.
Acidotic, thank you. Is it from a respiratory cause or a metabolic cause? Okay, Casey says respiratory. Is the patient compensating? So if we've got a respiratory issue, what is our bicarb doing? Becky says yes, patient's compensating. Fully compensated? No. Partially compensated? Yes. All right. And what is our compensatory mechanism?
Is it metabolic alkalosis?
You got it, right? Because exactly. So our bicarb is up. That's more base. So it's trying to pull our acid level, our pH rather, back up to normal. Nice work. So we can do as many of these as you want, but I think just trying to think it through about what's the patient doing, are they acidotic or alkalotic, and then taking a look at the CO2 and the bicarb, and then going back and asking myself, okay, I said it's acidotic, I said it's normal, I said it's alkalotic. How did I get there? Did I compensate to get there, or are all my just one value abnormal? All right. How about this one? Okay. Brad says we are in an acidotic state and that the cause is respiratory. Sounds good. Are we compensated at all? Becky says yes. Brad says yes. Are we fully compensated or only partially? No, partially. Okay. And what is our compensation mechanism? Yep, I saw you say it, Becky. Metabolic alkalosis. You got it. I'm getting pretty good at lip reading after a year and change on Zoom. Excellent. And so if you decide to go through these are very helpful because I was doing a bunch of them this morning, and it's good because it goes through and gives you exactly why you're choosing the correct answer or the incorrect answer. So it talks about kind of walking you through the whole thought process. So I found this site super helpful just to like do a bunch of ABGs to kind of get into the groove of thinking through like, what's my process? My process is figuring out if the patient's, what their pH is it a CO2 problem, and am I compensating? And if so, what's my compensation? Thoughts? Other questions, concerns? Okay, see a couple of nods, a couple of smiles. Was this helpful? Okay. So the goal of these sessions is to kind of have you guys provide questions ahead of time, just like you did this week, and then be able to answer those. If you have other questions, feel free certainly to speak out during the sessions, but it's really just to keep people kind of on pace for studying for the CCRN with a goal of taking the test either in mid to late November or early December. So we'll meet probably 8 to 10 times to get through all of the sessions. I'm going to try and record them. I know people have to work, people have lives, but this way at least you'll be able to, it's easier if everybody participates, but even just having you guys submit questions I think is helpful. Anything else for today? Otherwise we can wrap up. Cool. Well, thank you. Thanks for coming to the first session.
Thanks, Sarah.
Yeah.
Thanks, Sarah.
Thank you, Sarah.
You're welcome.
Yeah.
Yep.